Speaker tonight, if I can have all your attention, is Dr. Rick Arseneau, and he's going to be talking to us today about chronic pain in the emergency department. I think anybody who's read through his bio before, especially as an emerge doc, I'm just amazed that he does what he does, and super thankful that he does what he does, because these are one of the hardest things that we see in the emergency department. So Dr. Rick Arseneau is an academic general internist who works out of St. Paul's and BC Women's, and he's an associate clinical professor at UBC. His interests include chronic pain, fibromyalgia, and related disorders, and he's the director of program planning and a clinician at the Complex Chronic Diseases Program. He's also director of the Rapid Access Specialist Clinic at St. Paul's and director of the Internal Medicine Ambulatory Rotation at St. Paul's, and he's trained and certified as a group psychotherapist. So he's going to enlighten us all on what we should do with chronic pain in the emerge. Please welcome Dr. Rick Arseneau.
Thank you. Can everybody hear me? Everybody hear me?
Yep.
Perfect. I tend to be a low talker, so I don't talk about anything or do anything that's sexy or interesting enough for anybody to pay me any money, so I have no conflicts of interest to declare. So I always wonder, as emerge docs, if you should have this printed on your greens or wear this as a t-shirt for when you encounter patients with chronic pain. The other interesting thing about patients with chronic pain, and I did a quick review of the literature, is that chronic pain patients who show up in your emergency department are more likely than any other type of patients to write nasty letters to the hospital about you. So I'm also going to say that this slide also applies to my talk. Prepared to be disappointed. So pain is a very common presenting complaint. Non-cancer pain takes up about 10% of what you see. And in the past, we've been encouraged to liberally use opioids. And because of this, we've seen a huge increase in opioid use, and this has led to abuse, misuse, diversion, opioid-induced hyperalgesia, morbidity, and mortality. And apparently, as I read, pain is the 5th vital sign in the emergency department. So I want to start off with a true story. This guy is my carpenter, and he worked on my house several years ago, and he's done a few things around the house. And he called me to say that he'd hurt his back at work and that his pain wasn't under very good control, and would I see him? So this was a WCB case, and they did not want him to see me, so I had his family doctor refer him to me. And it was clear that he did have suboptimal pain control. And as we'll talk later, that even for nociceptive pain, there is a central component. So I started him on some pain medications. He'd already had 2 ER visits before I've seen him in the Rapid Access Specialist Clinic. So, but 3 days after he sees me, he calls me and he says that his pain has increased tremendously. And so I sent him to St. Paul's Emerge, and he had metastatic disease to the spine. And he has since died. So he had a very rare form of cancer. So interestingly, WCB did not want to image him because it was a work-related injury that seemed to be minor. So you may be aware of the American Canadian guidelines that have come out in the past year telling us that we are using too many opioids, and the bottom line of these guidelines is that when it comes to opioids, don't. There are a few subtleties, but that's the main message. And so in Emerge, you're kind of stuck because you've been criticized for underprescribing, now you're being criticized for overprescribing. You also deal with a population that's more likely to misuse or divert their opioids. And you also have patients who show up, family doctor's out of town, whatever, I lost my prescription, somebody stole my prescription. And so with these new guidelines, there's also going to be the law of unintended consequences, and it's already happened to me, which is why I'm really careful applying these rules too rigidly. So this is a patient of mine from BC Women's Hospital. I was seeing her for fibromyalgia. Unfortunately, she'd been started on opioids a number of years back, and her family physician, following the college and following the Canadian guidelines, started to taper her opioids. And what he did was he wrote prescriptions for the next year in a stepwise decrease. And so what happened is that this patient ended up going on the streets of Vancouver and buying fentanyl by mistake, and she died. And this is a case that has already made the newspapers in Vancouver. So types of pain: nociceptive pain from tissue damage, inflammatory pain, and then the two types of pains that I deal most with: neuropathic pain and central pain. So let's go over pain. You guys remember that there's two pathways, one for touch, one for pain. Gets processed at the spinal cord, brain stem, and the brain. And so with central pain, we talk about central sensitization, but there's also a process of peripheral sensitization. So what happens is you have sensitization and amplification. So mild touch or mild noxious stimuli is associated with decreased processing at the spinal cord. So there's usually an inhibitory process at the spinal cord, and then at the brain. And then this green thing is called the long descending pathway. So if you drop a piece of frozen fish on your toe, it hurts. As soon as it hurts, the brain sends a message back down to the toe that says, I got the message, stop hurting. And in patients with chronic pain, not only is there sensitization and amplification, but this inhibitory pathway is blocked. So if we look at the process of sensitization, on this side we have a normal sensation. We have our two nerves. We have our nerve that is transmitting noxious stimuli, and it's being processed, and to the brain is pain. And here, this is our long descending pathway, which is an inhibitory pathway. In normal touch, we have touch that goes down a separate route and ends up with the sensation of touch. What happens is, it's kind of like when you have chronic pain, any kind, is you send your pain system to the gym, and it gets really good and it gets really strong, so that minor stimuli actually set it off. And so you end up with hyperalgesia. And you can kind of see that this long descending pathway is faded out because it's not working anymore. But even worse, touch fibers are now connecting to the pain system through neuroplasticity, so that touch is being sent as pain to the brain. And depending on when you've went to medical school, but I went to medical school a long time ago, and what we were told is that glial cells were simply support structures for the brain cells. They really had no role. And I recently came across a 600-page book called The Other Brain, and it's all about the role of glial cells in the brain. And one of the things we've figured out is that chronic pain is a gliopathy. It's a sickness of the glial cells. And that's also the mechanism of opioid-induced hyperalgesia. So the idea is that opioids are fantastic for acute pain, but after a while, they wear off. And what happens is the only pain they're controlling is withdrawal pain. So I have had literally dozens of patients just in the last year come off of opioids, not in a stepwise fashion, but in a discussion with each change in dose. But what tends to happen is have your pain, it's here, spike of pain with a small dose decrease, you ride this out, and the pain comes right back to baseline. And you do this again, and again, and again. And what happens is that after a year, 2 years, patient's pain will be exactly the same as it was on opioids. And this is in patients who are in as much as 500 milligrams of morphine 3 times a day. So this is also the mechanism that we think low-dose naltrexone plays, because low-dose naltrexone is the oral version of naloxone, and we're using a lot of it in chronic pain because it tickles the same receptors as the opioids, but rather than causing a gliopathy, it actually improves glial health. And so this is also being used a lot in conditions like MS. So the bottom line through all of these mechanisms is that you have a shifting of the normal pain curve towards the left. So here is how much it hurts, and here is how much I'm hurting you. And this part over here tends to be done with a clamp. So in the studies, they apply a clamp and they start squeezing, and then they see how much it hurts. And so with a normal person, clamp is on, squeeze, squeeze, squeeze. At some point, it starts to hurt, and it continues to increase in terms of how much it hurts. In patients with chronic pain, it can occur even with touch, and this is where you have allodynia. And over here, you can see that this noxious stimulus, that's just mildly noxious, is being experienced as significant pain. These studies have been criticized because they say, well, this is subjective. Well, here's an fMRI study. Fewer data points, but you have exactly the same thing. You have pain intensity over here, and you have stimulus intensity over here, and here they're actually telling you how many kilograms per centimeter square. And so this had nothing to do with what patients were telling you. It had to do with how bright were the pain areas in your fMRI scan. And so a normal person with the squares, put the clamp on, you squeeze a bit, hurts a bit, squeeze more, hurts more. Patient with fibromyalgia, here I'm squeezing the same as here, the pain is being perceived as up here. So these patients are not making up this pain or are, quote, oversensitive, although they are sensitive to pain, but not in the way that we normally criticize them for. That they are experiencing pain at the same level as somebody else with a much more severe noxious stimulus. So let's look at what chronic pain patients tell us about being in the emergency department. They tell us that they feel desperate, frustrated, and helpless. They find it difficult to communicate. They sense a tension around their being in the emergency, and they feel defensive because they're suspected of diverting or misusing drugs. And this is a common story that I hear from my patients. Let's look at the flip side. So Emerge staff thinks that there's a mismatch between what patients need and what they can deliver. Patients would like to facilitate testing, access to specialists, treatment, and sometimes even a cure for their pain. And so you run into the problem of the fixers who can't fix. And so Emerge docs have been described as fixers, and that's why they went into Emerge, is they want to do something and they want to see a result. So you guys would hate the work that I do. And these patients have been described as heart sink patients. As soon as you pick up the chart and you see the reason for them being in the hospital, your heart sinks. The Emerge docs have described themselves as feeling disempowered, inadequate, helpless, frustrated. They don't like the fact that they're working with incomplete information. These patients are very complicated. They've tried a number of things before. They are more likely to have adverse reactions to medications. And so all of the doses that are in the CPS are actually incorrect for these patients, that if you start them at those doses, you're going to have problems. They also have a fear of making the future care of these patients more difficult. And so the bottom line is that they have a negative attitude towards these patients or a stigmatizing attitude. And this is a paper that I found. It was called Pain Recidivists in the Emergency Department. So the patients have been described as recidivists. Let's actually see what recidivist means. It means a convicted criminal who reoffends, especially repeatedly. So the fact that that is the title of an article in the literature is very telling. And then we have the problem of, is this patient faking it? Are they malingering? So hopefully this is less of a problem than it used to be. Because this is, I think, two perfect storms that come together. And it's a combination of hubris and what I call the Sherlock Holmes principle. And this has to do with all physicians, is that physicians, unfortunately, many of our colleagues are hubristic. And for those of you who don't remember that term from high school English, it means to feel like you have godlike powers. And so the picture here is Icarus and Daedalus flew too close to the sun and his wings fell off. You combine that with the Sherlock Holmes fallacy. And that is that when you have eliminated the impossible, what remains, however improbable, must be the truth. And the hubris in that statement means that you actually believe that you can come up with all of the possible things? Because in the past, and today still, for physicians, if I've ruled out everything that I can think about, it must be a psychologic problem. And so that's where we have the concept of somatic symptoms. And so we have this guy to blame because of his ideas about how the mind and body interact. And he's in large part due for the disconnect that we have in medicine of thinking of the mind as a separate entity from the body. So those of you who have caught up with the DSM-5 may have realized that all of these ideas around somatic disorders have been scratched completely out of the DSM. So there's no such thing as pain disorder anymore. There's no such thing as hypochondriasis. There's no such thing as somatization disorder. They've all been replaced with one thing, and that's called somatic symptom disorder. And that disorder cannot be used for unexplained symptoms. So this is completely turned on its head, the way that physicians think about pain and unexplained symptoms. I would say that it's caught up with the way that I and my colleagues have been thinking for the past 20 years, because we knew all along that there's no such thing as somatic disorder. Interestingly, in residency, I was actually diagnosed with a somatic disorder. I had itchiness all over my body that was unexplained. I saw 3 dermatologists, including the head of dermatology at U of T. They put me on antidepressants. Then I got into a new relationship and my partner started to scratch. I had undiagnosed scabies for 9 months and had been diagnosed with a somatic disorder. The irony of all of this is what somatic actually means. Somatic means relating to the body, especially as distinct from the mind. So to me, how this word has come to mean psychiatric among physicians is very sad. And we have to talk about the elephant in the room, is that most of the patients that you're going to see with these conditions have borderline personality disorder. And luckily, the DSM is also catching up with ideas around how we think about borderline personality disorder, that they're actually not a personality disorder. It's a problem of arrested development. So I'm not sure how many of you are familiar with the study called ACE, the Adverse Childhood Events, and how that predicts things that are going to happen for you in the future. And I came to these ideas kind of peripherally because some people have described me as a psychiatrist wannabe because I deal with eating disorder patients, addictions patients, fibromyalgia, chronic pain patients, obesity patients. And I was seeing tons of overlap between these patients, that often one patient had the other, and that a large proportion of them had borderline personality disorder. Luckily, I'm covered with Teflon when it comes to borderline personality disorder. I'm not sure what opposite problem that I have that makes me not bothered by these patients, but they really don't get to me. But especially when you understand the root of their so-called personality disorder, we now know that it's due to developmental trauma. And developmental trauma doesn't mean that you have to have been sexually abused or physically abused or verbally abused. It means that you've had a high-stress childhood, whatever that means. So childhood should be like a lion cub in the savannah. Mom and dad are watching, I'm playing, I feel safe. You shouldn't feel like a gazelle, where you're constantly on guard and you're constantly scanning the horizon for threat. And kids who are born in those kinds of environment, the parts of the brain that deal with threat get big. In fact, they're twice as big on MRI. And so they are more likely to develop PTSD later on in life, fibromyalgia, chronic pain, addiction, anorexia, obesity. And so these people are often stuck at a point of development where their trauma happened. So if you have an adult who acts like the terrible twos, or you have an adult who acts like a belligerent teenager. But it's not a personality disorder, it's actually a developmental disorder due to childhood trauma. And so, like I said, all of these things kind of come together, and I happen to deal with a bunch of these conditions, including fibromyalgia, myofascial pain syndrome, migraines, tension-type headaches, central abdominal pain syndrome. So this has been renamed. It used to be called functional abdominal pain syndrome. So all of the functional disorders are in the toilet. Interstitial cystitis, irritable bowel syndrome, pelvic pain syndrome, non-cardiac chest pain, temporomandibular disorder, and other pain disorders. So you can see that a lot of these have to do with chronic pain. And they're tied together through a concept called central sensitization. And so central sensitivity syndromes, there's an S here. I often see physicians say, this patient has central sensitivity syndrome. They don't. There's no such thing. There are central sensitivity syndromes, which is a family of conditions that include all of these. How much, let's a show of hands, who's had 1 or more hours of training on this in medical school? Nobody? Because still in medical school at UBC, there is no training on this. A recent study from this spring suggests that 1 in 20 Canadians suffers from this condition. And so you have a big gap between need and what's happening. And these patients use more resources. It's been estimated that this represents 1 in 5 visits to family physicians. No training in medical school. And so we have the syndromes, but then we also have central sensitization as a process. And so even osteoarthritis and all other forms of pain have central sensitization if they're chronic. So here you can see that a meta-analysis showed that duloxetine is helpful. So here's a randomized controlled trial in eMERGE that looked at what if we told our patients that this is not the right place and that what we can't do, and what if we sent their GPs a letter? And over a 1-year period, they prevented over 1,000 eMERGE visits. This is a review article that looked at what chronic pain should be, how chronic pain should be dealt with in the emergency department. It said, clear communication, consistent policies. The goal is to reduce the pain, 2 out of 10. Don't emphasize medications or testing. Patients should be aware that the role of the eMERGE is not to treat these patients. Cautious consideration for use of opioids. Cautious change in the patient's regimens that they're already on. Patient education, and a letter to a GP. So basically the same thing. Let's skip some of these. So for the doers who like to do, this is a missed opportunity according to your literature. And it talks about myofascial pain syndrome. An interesting thing, like central pain, most chronic pain disorders have a component of myofascial pain. And there's an easy treatment for this. It's called trigger point injections. So those of you who are interested, those of you who are trained out of country probably already know how to do this, but I get excellent results by sending my patients for trigger point injections. And that's something that's possible to do in the emergency. It only takes about a day to learn. So, just like I prepared you to be disappointed with my talk, you should prepare your patients to be disappointed. What I didn't see in the literature is having a handout for patients upon arrival to emergency that says how you're going to deal with chronic pain. And so if I were developing a program for emergency for chronic pain, I would have a letter when the patient presents and tell them that this is not the place, you should be working with your GP. Our goal is only to reduce your pain by 2 out of 10, nothing more, that we can't prescribe opioids or any new medications, that we won't replace your stolen or lost prescriptions, that we won't expedite tests, that we won't expedite access to specialists, and we won't admit you to hospital. And so, unfortunately, and eMERGE docs from St. Paul's may be angry with me, but patients with fibromyalgia figured out that my wait list at BC Women's Hospital is 2 years. That if they present to the eMERGE, eMERGE will send them to the Rapid Access Clinic, and they're talking to each other. And so the emergency became a quick way to access me in front of the line. So now any chronic pain patients who get referred to me at the Rapid Access Clinic, I decline seeing them, and I return their care to their family doctor. So here's a bunch of patient resources that you may want to have a look at for both physicians and for patients. And I'm finished 1 minute ahead of time. Thank you.